Good afternoon, everyone. My name is Dr. Verna, Vanderpuye. I'm a clinical oncologist at the Kolbu Teaching Hospital, and I'm presenting to you on current practice guidelines on the continent for managing ovarian cancer. This is just a brief slide talking about the histological types, and this was a study that was presented in 2021, showing that we expect an 86% increase in the number of ovarian cancer diagnosis, new cases on the continent compared to other countries, and also the fact that we have a high mortality incidence ratio. Unfortunately, it was only Nigeria that was studied in this trial, but it just shows you the difference compared to the Caribbean and the US. Also to show that in this study, Nigerians tend to present more with sex cord and germ cell tumors compared to other Caribbean blacks, US blacks, and US whites. And also to show that they tend to have non-serous adenocarcinoma types compared to other black women. Let's look at what happens in other countries. This was a study of cancer registries from 12 population-based registries presenting multiple regions, 11 regions, with over 5,000 women over the past 10 years. There were 13 deaths from 18,000 cases. As of 2020, we know that ovarian cancer constituted 2.2% of all the cancers, being the fourth most frequent in women, with 85% of them being epithelial, mostly with serous type. The median age at diagnosis was 50 years. Unfortunately, we can see from this slide that a lot of these women in the registry data had unspecified malignancy, so it wasn't classed properly according to histological stage, with countries like the Gambia, Congo, Brazzaville, and Zimbabwe, Harare, seem to have less incidence of diagnosis properly specified. But overall, you can see that there was a high incidence of epithelial cells and less in germ cells. Nigeria again seemed to have quite a bit of germ cell and sex cord tumors compared to the rest of us. But I'll say also that you can see that very few had diagnosis histologically. Again, like Middle Africa, Congo, Brazzaville, and other countries as well, mostly in the Western Africa. But most people are doing much better than they used to. Okay, some countries also had a high incidence of them being diagnosed on the death certificate as well, like we have in Uganda and other countries. So what are the prognostic factors? We know that overall outcomes for Africans are worse in terms of advanced presentation and overall survival. But some of the prognostic factors are being overweight, having a genetic predisposition, being detected early, having complete oncological surgery, receiving standard platinum-based systemic therapy. There's a study that actually showed that was recently presented, and even prior to the era of targeted therapy like PARP inhibitors and VEGF, we're able to have about 10-year overall survival in 20% of patients with advanced disease. So in spite of this, we can still do a lot. The next figure just shows you the overall survival 5 years in females diagnosed about a decade ago. And the only country that represented here is Algeria, and it just showed you that the survival is about 20%. But if you compare it to France, which is about almost 50%, overall ovarian cancer doesn't do too well. But worst of all for Africa. Why do we need treatment guidelines for ovarian cancer? From the previous slide, we are missing out a lot. I don't need to go over that again. Ovarian cancer tends to present with non-specific symptoms and with advanced presentation. There's very little data about how ovarian cancer is managed in Africa. We have improved access to diagnosis, but there's a limited improvement in the quality of care. We don't even have enough data to say whether we have improved quality or not. There was a systematic review of 32 papers showed improvement in outcomes with adherence to guidelines. Also, we know that there's a heterogeneity of histological subtypes, which are managed differently. And unfortunately, most of these recommendations, especially for advanced disease, are high resource dependent. What are the current guidelines available? We have the ones from high income and middle income countries. I mean, the Cancer Care Ontario, ASCO, ISMO with European Society of Gynecology, Royal College of Gynecology UK, the NCC and Guidelines mainly from the United States regional and country-specific guidelines. Then we also have other resource stratified guidelines from ASCO, NCCN for Middle East and North Africa, and then the NCCN for Sub-Saharan Africa, and the National Cancer Grid of India. And all these are available online. Why do we talk about resource stratified guidelines? If you look at the bar charts, you can see this just shows data from Canada, where they looked at real world treatment costs for ovarian cancer. There's over 2,500 patients. The higher cost was with the higher stage 3 and 4, over 100,000 per patient. And also interestingly, patients who were unstaged actually also had it was quite expensive to manage them as well. And these costs were not realistic for low to middle income countries. Access is a big problem. And so we need to find out cultural sensitive ways of talking to our patients to diagnose them early. The common theme among all the guidelines were refer to areas with high expertise. And what are the areas of controversy in resource stratified guidelines? I've been fortunate to sit in, a couple of them. And I think for me, the controversies were the diagnostic workup, whether to use just ultrasound or to use other modalities of imaging. But like I said, the information actually revolves quite fast. So at the time we're developing some of the guidelines, MRI and PET scan were not recommended for imaging. Maybe just a CT scan and CA125 in the ultrasound. And also FNAC and image guided biopsy were also not recommended. The extent of cyto in reduction, that is the size of whatever is left behind. Optimal meaning should be less than 1 cm versus suboptimal when it's larger than that. But most of us know that on the continent, most of us tend to have more of a debulking situation where a lot of tumor is left behind. Laparoscopic surgery is controversial, so at this point in the guideline discussion, and people from high income countries tend to like to push it as an agenda. We also try and have to know the origin of the tumor, even though the management is the same, whether it's from the ovary, from the tube, or from the peritoneum. Lymphadenectomy is now recommended only for early stage versus for advanced stage. For early stage, the AURTC action trial confirmed that the patients did better. And for advanced stage, the Lion study just showed that patients had more morbidities when you did a systematic lymphadenectomy versus just sampling. In terms of neoadjuvant chemotherapy, the data that is not strong in terms of it being better than upfront surgery. However, we should know that in our continent where we don't have that much specialists, it's different to have proper, complete or optimal debulking in patients who have large ascites, liver metastasis, splenic mets, and lymph nodes. So it's best if these patients had neoadjuvant chemotherapy. But then some people tend to still prefer upfront surgery. Repeat cytoreduction when the patient gets upfront surgery, and because it's inadequate, they have chemo and then go back. A lot of studies that have shown that it doesn't make any difference, except for one from the EURTC that was a positive study, but overall, it is not recommended. For recurrent disease, again, we thought that going back to debulk was the best thing to do for patients with recurrent disease. But then the desktop over trial came out. There's also the eye model, which is more like a modeling program, and it showed that patients with good performance status, long disease-free survival, very low CA125, and very minimal ascites are those who benefited from this surgery. So you really have to be careful what kind of people you send for that. Genetic testing, again, in the high-income countries, recommended for all cases. It's quite difficult for us, but we can talk about genetic counseling. 3 versus 6 cycles of cisplatin for early stage disease. This was promoted many years ago by the European, mainly the British. There was a recent update in 2017 on randomized trial, which shows that 3 cycles could be equivalent to 6 cycles for early stage disease. Again, so many other trials could also support that, and even recently the GOG 157 as well. But however, this is not promoted in the United States. In terms of second line treatments, a choice, there's a wide choice, and that is always controversy between high income and other regions. And in the use of bevacizumab, the endpoints were not really overall survival, except in only stage 4 disease in patients with ascites. It was more of a progression-free survival. So for us, it also became an issue in terms of the cost as well and the cost-benefit ratio. Let's look at the ASCO ovarian guidelines, resource stratified guidelines. In terms of symptoms, they use more of the ultrasound. This was done about 2019, so it's a little bit older. And the ultrasound seemed to be the most important thing in diagnosis, in addition with the CA125. And then the use of MRI was not very strong evidence. The evidence was weak, and it was only for enhanced setting CT scan for limited and enhanced setting. In terms of metastatic workup, staging surgery, all patients actually should be referred. And so no surgery should be done in the basic setting. Looking at the low risk stage 1 and 2, refer to the limited or the enhanced setting, and you could actually do fertility surgery. It was stage 1 or higher, refer to a higher level for proper surgery. You could still do fertility sparing surgery also in the enhanced, but the evidence was still weak. In terms of high risk stage 1 and 3, combination adjuvant therapy could be given in the limited setting, and if it was with stage 3 disease, you could actually also consider targeted therapy if you're in the enhanced setting, and the evidence was not that strong at that point in time. For neoadjuvant chemotherapy, up to 4 cycles, again, I've spoken about that. At that point in time, the evidence was not too strong. For patients who were metastatic after receiving surgery, stage 3 and 4, you could actually, after receiving chemotherapy, like in the neoadjuvant setting, interval debulking is not recommended in the basic, but in the limited, you could do surgery if there was some response or at least a stable disease, or else don't do anything, or don't do anything and leave anything behind. For those who have had surgery for the adjuvant setting, if the patient has not had complete suboptimal staging, you need to go back and do more surgery and then give more treatment. Okay. And in terms of maintenance chemotherapy, it was only in the enhanced setting where you need to discuss maintenance therapies, the anti-angiogenesis, and other targeted therapies. In terms of recurrent disease, surgery was only recommended for very small platinum-sensitive disease, where you complete the surgery. And for patients who've had previous surgery, chemotherapy, it didn't really change anything. It was best to do palliative care. You could also refer to a higher center, and for platinum-sensitive or platinum-resistant, you could get second-line treatments. And the other option was to give chemotherapy with or without targeted therapy. When they are resistant, you only give non-platinum single agent. Giving combination did not change anything with or without a targeted therapy. Let's look at the NCCN Sub-Saharan Africa. And what we did with this is just to highlight in blue what we want for our region, and then blot out what is really not available. So with this workup slide, what we added was that we needed regular gynecologists in here, because we had more gynecologists than we had gynae oncology, and also that genetic testing was actually not available. So we blotted that out for most of Africa. In terms of optimal cytoreduction, again, referral to the gynecologists, and then germline mutation was also blocked out. Now, when it came to primary post-surgery treatment, we realized that we blocked out a lot of targeted therapy and the use of genetic testing or genetic subtypes in their treatments completely from this guideline, and included the use of basic staging workup and follow-up workup like chest and abdominal ultrasound for surveillance. And so that's different from what we regularly had. In terms of the regimens as well, as you can see, in terms of stage 2 and stage 4, we blocked out anything that had targeted therapy, because that was the access was poor in general, and most of the other basic chemotherapy were available. And in terms of for patients with recurrence, again, we blocked up a lot of the targeted therapies as well. Now, for patients with different types other than the mucinous, the other different types like the endometrioid, mucinous, and low-grade serous, mainly, I'm sorry, this is the slide for Middle East and North Africa, and just to show you, this is for patients with primary stage 2 to 4 and low grade. You can see that not very little was, in fact, nothing was blocked up, just to say that bevacizumab was only for stage 3 and stage 4 disease. And in terms of the workup for recurrence, PET scan, MRI, CT were all recommended compared to what we had in the sub-Saharan Africa. Again, let's look at the national grid of India. It looked at early stage, they did CT scan and MRI was recommended just to differentiate between benign and malignant disease. For locally advanced, staging laparoscopy was recommended, and the PET scan only for recurrent disease. It might help with the staging. And also interventional radiology, they recommended image guided biopsy, which was not recommended in the other guidelines, and also genetic counseling only for high grade serous. All right, surgery was almost the same. For adjuvant chemotherapy, they recommended 3 to 6 cycles of carboplatin, but for high grade serous, recommended 6 cycles and or 6 cycles of carboplatin. For surgery, interval cycle reduction after 3 cycles of neoadjuvant, and they agreed that the outcomes were similar versus upfront surgery, but then it limited surgical mobility when you use that. In terms of chemotherapy, because patients might need more surgery, under these settings, chemotherapy was to do with 6 cycles of and they actually went up to 8 cycles, which may have not been shown to show anything. The patients with poor performance and comorbidities were to have carboplatin only, and the use of intraperitoneal chemotherapy and targeted therapy was optional, and you need to discuss that with the patient. Same with recurrent disease. They recommended chemotherapy based on whether it's platinum sensitive or not. For platinum resistant, they only had very few options, and the use of bevacizumab or targeted therapy. And then for cyto reduction, only those with low-grade disease were recommended. Again, the difference here is the use of radiotherapy for oligometastatic disease, and they also included germ cell tumors in their treatment. So in conclusion, there are several guidelines existing for ovarian cancer. The limitations are diagnosis, surgical techniques, and drugs. Multidisciplinary care is key in areas with limited specialization. Patient preference should be high on the agenda. You need to discuss all options with the patient. Be realistic about the outcomes, even in current therapies. Consider the management of toxicities, compliance, and the health system strengths. Review guidelines as evidence is rapidly evolving. Critically appraise new evidence in the context of resources, and be fair to the patient and refer to specialized areas. I also like to talk about 2 cases that I would have liked to present. One is a 57-year-old who presented 3 years ago with metastatic, not low volume disease, high volume disease, metastatic mucinous carcinoma of the ovary. Because she had a poor performance status, we gave her 6 cycles of carboplatin. 3 years later, she has recurred. She still has low performance, the performance status is quite low, and we are reconsidering carboplatin. But in other settings, would you add targeted therapies? We don't do routinely the genetic testing yet to see whether she could benefit from PAP, because most of them cannot afford it, or just pure palliative care. Now, we also have a second case who's about 75, who was diagnosed 3 years ago with stage 3C ovarian cancer. She received carbotaxol for 6 cycles. She said she couldn't afford Avastin then. And then a year later, she recurred again. She was platinum sensitive, so we challenged her with gem and cisplatin. And another year, she recurred again, and this time she agreed to have bevacizumab. She's completed 6 cycles, which is 4 months. Her CA-125 has dropped drastically. She has a good performance status, and we are discussing further continuation with bevacizumab. The problem is that it's almost difficult for her to complete 2 years or even 1 year of bevacizumab. So we are trying to complete 6 months. I don't know how far that would go. So what would be your recommendation, with that? Thank you very much for listening.